6 weeks. 6 weeks is just where we start to clear you to do things. It doesn't mean your body's done healing. It takes about a year to fully heal.
Just crazy.
And so, yeah, it is crazy. And so we tell patients, if you're going to run, then you are going to have swelling, and it's normal. And if you wear your, you might want to wear your compression those days before you go running, or, after you go running, for example, just to help with some of that swelling. And again, everyone's different. Some people, can run at 7 weeks and not swell, and others are going to blow up like a balloon. So I think a lot of it is just you have to see how your body reacts and then adjust accordingly.
Can you wear it while running?
I mean, it's probably going to be hot in Florida, but you can, yeah.
Hey, we're in Oregon. We can totally.
Yeah, that's true.
I hate compression. I was very, very compliant. I did exactly what I was told to do, but by the end of the 6 months, I wanted
you were
to
like
burn it.
Last day done.
Yeah, no. And then the funny thing was,
you're like most patients.
Yeah, I just hate being squeezed.
Hey guys, it's Mel, your host of the Cutting Edge podcast. This is a show where we talk transformation from every angle: body, mind, and confidence, with a little sparkle and a whole lot of truth. I'm joined by my amazing co-host, Dr. Omar Beidas, and the plastic surgery pro, and Ashlyn Douglass-Barnes, our go-to therapist and mindset queen. Now, quick disclaimer, none of us are your doctor or therapist. We are just here sharing real talk, real stories, and real growth. So grab your protein shake, settle in, and let's get into it. This is The Cutting Edge.
Hey, it's Ashlyn. Just one more thing before we begin. I will be sharing some of my own plastic surgery journey, which is personal to me and may not reflect what others go through. And if you're a current client of mine, please talk with me first before listening, because knowing personal details about me could affect your therapy, and your well-being always comes first. Now on to the show.
Welcome back to the Cutting Edge podcast, and I am your host, Mel.
I am Ashlyn.
Omar Beidas.
And today we're going to be talking about how to have an actual really good experience post-op. We know there's tons of questions out there, and we have the best two people to help with this, considering all the experience that Ashlyn's had as a plastic.
The best. No, sorry.
I love it. So where would even someone start? Like, how do you even prepare for a good post-op situation? I don't even know.
I think it starts in pre-op.
Start with the actual, yeah.
Okay, so it starts in pre-op. Good to know. So what do we do? What do I buy? What do I not drink? What do I not eat? What are all the things?
So for me, I would say, and this is something we stress at the time of consultation, because at least during the consultation, even though we're throwing a lot of information at you, it's a good time to stress the importance of protein, right? So for us, protein is one of the things that's going to help decrease your risk of complications. It's going to help you heal, recover faster. There's a little bit of nerdy science behind it, but protein is what makes your muscle, right? So if you aren't protein loaded ahead of time, your body's going to start breaking down muscle, right, to pull that protein out and help you heal your wound. Okay. So that plus, and even if you're protein loaded, your body will pull some protein out of the muscle. But that plus immobility, right, or kind of the lack of going to the gym while you're recovering, because that's one of the restrictions, is some of the reason, or combine the reason why people lose muscle mass as they're recovering from surgery.
Okay, so no matter what, you're going to lose some muscle mass, it sounds like. Mm-hmm.
No matter what, you will lose some muscle mass.
Oh, I've never heard that before. Okay.
Yeah.
Good to know. I mean, I always knew protein was healing, but it's going to pull from your reserves.
It's going to pull from your reserves, but the more you pre-build and the more you eat throughout, and people generally have to supplement when we're talking about over 100 grams of protein a day, right, when you're recovering. And then the more you kind of build up ahead of time and you eat or supplement throughout your recovery, the better you are, the better off you are. The less your body has to break down from its own muscle.
Okay. Now, did you feel that, Ashlyn, when you went through yours?
I did not know for sure in the first time, and the second time, probably not. I didn't know about preloading the protein. I knew post-op I needed to make sure I had enough protein, and I was specifically drinking protein drinks, even though I don't normally do that. Often too, because I just didn't feel like getting up and moving and eating. And so I was also relying on other people to help me. And so just how I am.
Yep.
I wasn't as often being like, can you bring me more food? More I was making sure I had like cold protein that was just kind of always available. So I was just kind of refilling it as it emptied, and then just trying to sip on that during the day in addition to like hydration. You know, it's interesting. I'll have to look this up. I'm going to say this anyways because it's something that comes up a lot. And I wonder if it's like the same idea. So a lot of people get some depression post-op. And what I was thinking of when you just said that about the muscle is I know when we work with clients who self-harm or like cut, part of the issue that those clients get into is there's this cycle. Your body releases serotonin when you heal, particularly. So if you create a cut, there's like a serotonin release, and that actually can drop and make you feel more depressed. And then it's kind of the cycle people get trapped in with cutting. And I wonder if that's part of where that is. Have you ever heard of that, Dr. Beidas? Is that part of the? I know, like, it's a pretty common reaction for people to have, not necessarily depression from like they aren't happy with their results or anything, but just general like lower mood is common. Do you think that might be the
It
reason?
is common. I don't know that it's related to the cutting, I guess, if that makes sense.
Right, because it's more from that healing, like your body sends out the serotonin to heal, and so it's kind of like overloading.
It's an interesting idea. You know, I know a lot of our patients who, like, I saw a patient last week, for example. He goes to the gym 5 days, 6 days a week, right? I told him, okay, no gym for 6 weeks. He said, I can't do that. Like, there's no way I'm having surgery ever. He's like, I will not have skin removal if it means I've got to be out of the gym for 6 weeks. I said 4 weeks. He said, won't do it. So I'm trying to negotiate. He wasn't having a major surgery, but regardless, I would say the minimum is 4 weeks if we're talking about like lipo, for example, which was a lot of what I was doing for this gentleman. But the patients who are like gym rats, and I've had a few of them, they generally do the best, to be honest. I mean, those are the easiest patients. They're already doing well with their protein. For the most part, you don't have to tell them to do more because they're already doing enough. And then they're already fit. They've got good muscle reserve. Those patients, for the most part, heal like that. And then the problem for them is, and I think maybe this is where the depression comes from, Ashlyn, is they can't go back to the gym. So like they feel good enough to go back, but we have to tell them you can't. You're not ready. You know, you're not healed enough.
Right.
And
And
I know
definitely
some
if
of
that
the
was your mental health, that was part of your mental health. That was your community, the people at the
Yep.
gym, they are used to seeing them all the time. That was
Yeah.
your like, check, I did something good for myself today. It also takes up time, which if you're just like sitting around reflecting on things, that isn't always the best for some people. So yeah, I'm just trying to think of like the people that are not gym rat. I think it's a common occurrence, and I've always kind of wondered like what that was from, and that's the only thing I could come up with because I know
Well,
that that's a.
I think you're onto something though, Ashlyn, because even with say the gym rats, they're so used to even the dopamine,
Oh,
That's their
serotonin,
dopamine. Yeah,
all this
exactly.
stuff, and then they
That's their
can't
high.
have it. And then, it's not as much as obviously what you normally used to getting. And then with the cuts, you are getting that. And what do you call it? Is it a serotonin dump?
specifically for cutting, it's serotonin that we look at because it depletes it. And so if you're already depleted and then you're depleting further because your body will push it out to start the healing process.
Okay.
So
yeah, I think that might be a combo. It would make sense, at least to me. I know what it feels like to have your serotonins drop, and then you're like, you feel like shit for a couple days.
Yeah,
So.
it's weird. And obviously I don't know if that's correct, but I think it's the issue of be aware that's a common thing that happens. It's normal. It will go away. It's not the new you. It usually has to do with the healing process. It's a very similar thing happens after bariatric surgery for a lot of people, but that has to do with the hormone release from rapidly losing weight in the fat cells.
Yeah.
So like that's well understood and established, but and usually a little worse for women because it'll bring on a really hard period because of estrogen release.
Oh boy, does it? Oh boy.
So, and then that can create a roller coaster. So I don't know. It's more of the issue, I guess, is less important why and more important that it can happen. So like have your support system. Like sometimes it happens when everyone leaves because they're like, she's good. It's been 3 weeks. She should be back to normal. And then it's like, oh, everyone left and I don't feel particularly great, or I'm tired of this. I'm tired of sleeping on the couch. I'm tired of feeling like a busted can of biscuits when I take off this faja. That's like, oh my God, I felt like my
Never
guts were
heard
going
that
to fall out.
analogy.
Oh God.
Really? A busted can of biscuits? You haven't heard that?
Oh, you never, that you want to feel like a busted can of biscuits, put a faja on and then like release the, makes this awful noise too. And you're like popping them all off. Like, get off,
Oh,
get off.
does it? I've never
Yeah.
worn Faja, so
They're terrible because if they're proper, they are tight. It's one thing, I don't tolerate anything that's tight. So like to me, the worst part, and the surgeon I had like loves for you to be in a faja as long as humanly possible. Like I think in 6 months I was still sleeping the like last 3 months.
Goodness
I was about
gracious.
to ask Dr. Beidas, is like, what are your rules around Faja and compression, and like how long do you normally keep them in there? Like,
Yeah, so faja is another term for compression, and I think it's a Spanish word. And we do a minimum of 6 weeks, and we tell patients everyone's different. So some patients are good with just the 6 weeks, some need it a little bit longer. After 6 weeks, if you need it longer, we generally recommend kind of weaning, so 12 hours on, 12 hours off, and we let patients pick daytime, nighttime. I warn patients ahead of time, though, that people who, like if we're doing 360 lipo, or if I'm using an energy device, like we have ultrasound assisted lipo, which is like a Vaser, or if we do some radiofrequency tightening, we recommend the full 3 months. So 6 weeks all the time, and then 6 weeks on, 12 on, 12 off.
you just say
And people, sorry,
you have an ultrasound phaser?
Vaser. It's an
Wait.
ultrasound assisted liposuction device, like laser but with a V, and it has nothing to do with lasers. I don't know why they made it rhyme.
I was thinking Star Trek, so I'm like, phasers. Like,
Oh.
what are we doing? Okay. I'm like, we've definitely like come from, old days to now. Like a lot of things that are on Star Wars and Star Trek are actually like real life now. So it's like, wait, do we have
Goodness.
phasers and I don't know about it? Like,
What is I've never seen Star Wars or what do phasers do? Are they
They're like
not a lightsaber?
no, that's a lightsaber. A phaser is like the little guns and they shoot at you and they like little lasers come out and they can either stun you or they can actually like zap you like a laser. I am such a nerd right now, but like,
well, I nerd out about surgery things all the time, so
oh my God. Okay. So you'll have them in there for 3 months total if they do a 360. That makes sense.
if they do, yes, 360, it's always minimum 6 weeks. And then after that, like I said, it's weaned, but we tell patients who are getting, one of those 2 or 3 things, we'll tell them you're probably going to go the 3-month route.
Have you ever had someone go like, I want to wear it longer? Like, has that ever come up?
Mm-hmm.
Okay. And then
not infrequently. I would say some patients they feel comfortable in them. And they say, I'm just going to keep wearing it. I wear it during the day. Some of the things patients don't realize when we try to explain them, if you're 7 weeks post-op and you go running for 10 miles, you're going to swell, right? Your body's still not fully healed.
Hey friends, this episode is sponsored by findabariatrictherapist.com because bariatric life is full of ups and downs and everything in between, but you don't have to go through it alone. Findabariatrictherapist.com makes it easy to connect with therapists who truly understand your journey, the mindset shifts, the identity changes, and all the real-life challenges that come after surgery. Because therapy designed for bariatric patients changes everything. Visit findabariatrictherapist.com and find your support today.
6 weeks. 6 weeks is that's where we start to clear you to do things. It doesn't mean your body's done healing. It takes about a year to fully heal.
Just crazy.
And so, yeah, it is crazy. And so we tell patients, if you're going to run, then you are going to have swelling and it's normal. And if you wear you might want to wear your compression those days before you go running or, after you go running, for example, just to help with some of that swelling. And again, everyone's different. Some people, can run at 7 weeks and not swell, and others are going to blow up like a balloon. So I think a lot of it is just you have to see how your body reacts and then adjust accordingly.
Can you wear it while running?
I mean, it's probably going to be hot in Florida, but you can, yeah.
Hey, we're in Oregon. We can totally.
Yeah, that's true.
I hate compression. I was very, very compliant. I did exactly what I was told to do, but by the end of
You
the 6
counted down the
months, I
days.
wanted
You were
to
like
burn
last
it.
day done.
Yeah, no. And then the funny
Most
thing was,
patients are, you're like most patients.
yeah, I just hate being squeezed. I don't like that feeling. I don't like that, like, and I'm sure it makes you look like, I have clients that are like, I wear them all the time because I think they make me look great.
Yeah.
I'm
Well,
like,
I
you couldn't pay me money.
think a lot of, I mean, I shouldn't say a lot. I know some South American women wear them like daily because it like
Yeah.
helps them get into a tighter, dress, skirt, whatever,
Yeah.
pants. They feel better.
Right. It's more to them like undergarments, but like,
Mhm.
Yeah.
I'm good.
Because I've seen some women online that are just like, they just wear them all the time because they're like, well, it keeps I feel completely snatched, as they would say, and feel really good in them. And so they keep wearing them. And I was like, could that hurt you by any means? It doesn't sound like it. It just helps with circulation. So why would it hurt them, I guess?
It couldn't hurt you, no. Yeah, but then it is not infrequent, but we do have patients who come into like their 6 months and we're checking them and they, they're undressing and they've still got their compression garment on. And it's like, you don't need this anymore. And they're like, I just feel more comfortable wearing it. Okay, great. You do you.
Okay. So we've covered Fajas. And we covered like we got to pump up our protein and pre-work. What else can we do to help healing?
I think Ashlyn mentioned this earlier, but one of the things we ask also during as early as the consultation is the support system, right? Who's going to help you after surgery? Even maybe before surgery, right? You've got to think meal prepping, right? Who's going to cook you meals, or what are you going to do after surgery? Who's going to help you get around the first few days, the
And
first week?
who's going to listen to what you're supposed to eat? Because you can't have a ton of salt.
Right.
So
Yeah.
if your person is like, I don't really cook, so I'm just gonna heat you up soup after soup after you're gonna have to be good at being like, I cannot eat that right now because that's gonna increase my swelling, which is uncomfortable and could cause pain.
But overall, your support system, right? Who's that support? Whether it's mental, whether it's physical, whether it's help around the house. If you have kids, especially our moms and dads with little kids, you can't be picking them up. It's tough to start doing drop-offs and pickups and things like that, activities. So, what's we want to make sure patients have a plan and they have help for at least the first 2 weeks, right? We have patients who come from out of town. Where are you staying? Who's coming with you? How many days before, after are you staying? We want to make sure we plan for all those things and that patients have the right tools.
Well, and I'm just going to do a shameless plug for the Bariatric Warrior, because bariatricwarriorsupport.com now is like, she is a nurse to where she can go to you. So, and she's done it for people right after for bariatric surgery and plastics. So she is someone you definitely would love to have around because she knows all the things. Like, she can make sure you're eating correctly, moving correctly, putting your fajas on. Like, she helped Bex to take a shower, do the whole nine. Like, she's fully hands-on. So there are services out there that can help you with those things. So if you don't have like local support, family support, or if you would rather just have someone that knows exactly what they're doing with you, go to them. Like, I was thinking about it because I was talking to her like a week and a half ago, and I was like, Dr. Beidas does my stuff. Then, she's not that far from Florida. So, because I think she's in North Carolina. So that's not that bad.
She's down here all the time, though. There's a direct flight from Asheville to Orlando.
Yeah, 100% can just like, I could fly over, hang out, and I would actually probably try to stay in Florida. No, I'm not gonna lie, guys, like for probably 6 weeks. I just do the first 6 weeks. I'm not even coming home. That way everybody can just see when I come home and just get off the plane all like, yeah, let's go.
In your faja.
In my faja.
Okay, so let's talk about that. So like the first set of surgeries I had in Jacksonville at Mayo Clinic. That's where my doctor was.
Okay.
And so his rule was I had to stay for a week. So at the time, Mayo Clinic had a hotel literally they wheeled you out of your room and they would wheel you into your hotel room.
Like a hotel room. Mm-hmm.
Yeah, it was fabulous. And then he could come see me. Now I stayed overnight, I don't know why, and all of mine with him. And then I went home I would go to the hotel the next day, but then he would come do checkups like in the room with me.
But you're like Jacksonville is not like a 6-hour drive. I would consider Jacksonville, which we have patients come from, like St. Pete, right? That's the west coast of Florida. It's about 2 hours away. I
It was
consider
his
those
rule.
local.
Why did I stay overnight? I don't
Yeah.
know. I didn't need to stay overnight. They didn't do much for me. They just made sure I was alive.
Is this the same guy that has like the?
Yes, the one with the tape. Yes. How
What?
many?
What? Sorry.
He had how many inches of scar line he would do?
Yeah.
Huh.
See, he just has some funky rules.
Yeah.
100%.
So yeah, I stayed there for a week. I think my mom came with me. Maybe my husband came with me. My mother-in-law. I think my mother-in-law stayed with me one time. But it was good. I mean, I heal really well. I'm weird. So I'm up. I can't take opiates. So I mean, I was like up and walking. I felt very bad for the hotel because I'm sure I dirtied up some towels and stuff, but I would just like walk up down. But it's Mayo Clinic. Everybody's there first. Their first thought was not that I was there getting plastic surgery. That's for sure.
Yeah, Mayo Clinic is for a lot of different things.
Yeah.
Definitely not plastics.
So what would your recommendations be for like if people are coming from out of town? Like how long should they stay? Like do you recommend like recovery homes, or I know those are more popular down in South Florida?
Yeah, that's an interesting concept. Recovery homes, I think, are I don't. We could talk a whole episode on that. So, and there are some in other big cities, like I know in LA and Beverly Hills, there's a few. I think some of them are in hotels, but like a true hotel. And I think in Chicago there's one, and some of them are like we're talking like Four Seasons or Ritz-Carltons, like they're very high-end hotels, and they have a wing for patients to recover in. Obviously, that comes with a price point. In Miami, they're usually like, I've never seen them, but I've heard they're not the cleanest, not the best. Definitely, I've not heard of them being in a Four Seasons. Maybe they're out there.
They're in like a fucking Motel 6 or something. Just like
I think
I
they're
don't
like
want to say
people's
Motel 6,
homes.
but
Yeah, I think they're mostly like people's homes.
or like a Days
Heard of-
Inn. I'm not gonna lie, I stay at Days Inns, but I would never try to recover.
yeah, you don't want to recover in a Days Inn.
Oh boy. Oh boy.
And so I would say, I don't want to make a general statement, but I would say make sure you know where you're staying and who's going to be coming to care for you. And if there's like a nurse's aide, is there a nurse? Like who's checking on you? Is the doctor coming to check on you while you're there? For us, I would say, our general recommendation. So if you're coming from within a few hours away by car, I recommend patients, especially if they're having a big surgery, I tell them, especially if your surgery is 7:30 in the morning, you've got to be there at 5:30. If you live like an hour and a half, 2 hours away, you may want to consider coming in the night before, staying at a hotel, just to make it easy the next morning so you're not getting up at 3 in the morning. And then going home that same day if you're comfortable, or again, maybe the night of surgery, you spend another night and then you go home. And we'll usually see you in the office the next day. So basically, you come in the night before, you have your surgery, sleep in the hotel, see us the next morning in the office, and you drive home. So you've stayed 2 nights and we've done 1 visit and the surgery.
Okay.
When you come from a little farther, then we kind of leave it to you. Like we get people from Miami that's 3 hours away, or Tallahassee is about 5 or 6. Then people might want to stay a couple of nights before or after. Kind of same idea, do their surgery. We see them for 1 post-op, maybe 2 or 3 days later while they're still in town. Then they'll go home and then come back weekly or every other week, or some schedule. We don't make it too crazy to drive. We don't want people driving 6 hours every week.
Yeah.
And then we are going to have special precautions, like, maybe we start them on blood thinners because we know they've got long drives. So, one of the safety things that we really consider is anesthesia is a risk factor for blood clots in the calves, right? So that's danger. And then plane rides or plane and car rides and trains and anything where you're basically sitting for a long period of time. Air travel is a much higher risk just because of the altitude change too and the pressurization. So long car drives, long train rides, and then any length flight. So that we want to take into consideration. We don't want people driving back and forth. We might put them on blood thinners to help decrease the risk of blood clots. And then people who fly in usually will say 10 days after surgery and like a few days before. So almost 2 weeks altogether.
So even if they flew in, did the 2 weeks, would you still put them on blood thinners when they go home?
It depends on the patient, depends on how many risk factors they have. I don't think it's harmful to do it. So I know some surgeons do it for all their out-of-town patients. I've considered doing that, to be honest, but we haven't done it yet. But younger women, healthy, again, patients who are traveling halfway across the country are generally healthy. Sorry?
Yes, no suggestion of smoking. I know that's like
Oh yeah, no, we don't operate
you're
on
not
smokers
supposed
at
to
all.
smoke anyways, but I would say if you have any inclination that
Yeah, no.
Yeah, I mean, we actually nicotine test all our patients. So if you test positive, we cancel your surgery. It's a very, very, very high risk habit
So
or
you're
risk.
only testing for nicotine? Is that the biggest problem, or tobacco, or like how does that, like what are you
Nicotine. Yeah. So, people are always like, well, I smoke marijuana. I mean, you do you. It's not a safety issue if you do marijuana. For us, the nicotine is what matters because so marijuana doesn't have any kind of peripheral blood effects. What nicotine does, though, for illustrative purposes, if it's going to take a nice big artery that's this size and then shrink it by half or a quarter or a third. And so what then happens everywhere to your skin, right? And I mean, all your tissue, but really we're talking about skin and plastic surgery, is your body, the blood vessel is not able to bring as much oxygen and nutrients to that tissue. And so many studies have shown the risk of complications in terms of like wound healings and wounds separating, bad scarring is up over 10 times if you smoke or use nicotine. I keep saying smoke, but
you hear that, people? No more nicotine in your bodies. It's so bad
no
for
nicotine.
you.
And if you've had bariatric
bariatric.
surgery, I imagine your surgeon also, I don't know of a single bariatric surgeon who does those surgeries on a nicotine user.
Yeah. I know
patches, gum. Yeah. Patches, gum. So similar to that, again, I'm going to nerd out here, but similar to that, when they are going in and whether they're doing a sleeve or a bypass, they're cutting tissue, right? So they're stapling your stomach across.
Yep.
Or stapling across your stomach. So this incision line won't heal if you're a smoker or has a much higher risk of breaking down. Or if they're doing the bypass, the parts that they sew together, that suture line can break down and cause a leak, right? That's one of the complications they talk to you about during the bypass.
Marginal ulcers are the big thing with smoking. You can
So-
almost, especially smoking and NSAIDs together is
And
like
NSAIDs,
the
yep.
absolute like worst combo.
Yeah.
Would you say smoking and what together is the worst?
NSAID, so Advil, ibuprofen.
Oh, got you.
Non-steroidal anti-inflammatories.
Yeah. Okay. So no nicotine beforehand and no anti-inflammatories beforehand.
Anti-inflammatories for us are okay. Just the blood, we want to avoid blood thinners like aspirin,
Oh, gotcha.
Coumadin, Eliquis, those things.
Okay. Because like I've known several people through the community that had to stop before bariatrics, and then for some reason picked it back up, and then they had to stop again for plastics, and now they don't. It's funny, after plastics they don't. Almost everybody I know, actually, no, all of them, they don't smoke after plastics. So I'm wondering if they're just like not worth it, but also good for them. But like how far out do they have to stop smoking before, like for you to detect it? Like is there like a range that they should be doing?
Depending on the test, so we do a urine test and it can detect it generally 2 to 4 weeks. So I tell patients to stop for 4 weeks beforehand.
Okay.
And then we also like 4 weeks afterwards, right? Because if you pick it up again, your risk hasn't really changed much. So
no. And then what happens? Like, do you test them on day? Like day of surgery? Or do you test?
Our policy, so what we do, if someone admits to smoking at the consult, we won't give, this is like a 2-step approach. During the consult, if they don't smoke, okay, you're good to clear, good to schedule. You'll get tested at the pre-op appointment, which is usually 2 weeks before surgery, 2 to 3 weeks.
Okay.
And we do warn everyone that you're going to get tested. So like, don't lie to us about smoking.
Yeah.
Because one of the things, people, again, who smoke marijuana might roll it in like a cigarette.
Like a tobacco, yeah.
Yeah. Or people who use patches can test positive. People who use nicotine gum, like they're trying to quit. Now, if they admit to like, yeah, I smoke. Okay. So then our kind of protocol for that is we're going to give you a lab test order.
Okay.
Stop for 3 weeks or 4 weeks, and then go do the urine test. If it's negative, then we can give you a surgery date, and then you're going to get tested again at that pre-op appointment.
Okay, perfect. So
we've had a lot of people quit and then pick it back up again.
Not to tell people to smoke the night before, but like I've seen people do it though. Not with plastics, but with regular surgery. And I'm just like, what the fuck are you thinking? Like the problem
is you're only hurting yourself, right? I mean, yeah.
Like, it's scary. Like, I know, I mean, it hasn't happened personally, even with Eric's trauma, with his traumatic experience with his surgery. But like, I've heard of people like, having blood clots, and literally, like you said, it's in the leg, and they have to figure out, like, okay, we got to give you blood thinners, we got to monitor it, make sure it doesn't move, like all these things. So it's really, I just feel like it's just not worth all of that. Like, it's just scary. Okay, so no smoking, and we need to have Fajas, and we need to have lots of protein. And are we doing any vitamin recommendations? Like, are we making sure all that's good? Does that matter to you as a surgeon?
Vitamins don't matter that much. And actually, we usually have patients stop all kind of vitamin supplements, all that stuff for 2 weeks beforehand, because some of those things actually can also thin your blood, right? So, you have to realize vitamins and supplements and herbs and all these things aren't FDA regulated. So, people on ginkgo, for example, right? You might buy one brand and then, so Mel might buy one brand, Ashlyn might buy another, and they could be totally different things. And even from the same company, you can have two bottles that have very different, same thing, same brand.
Right.
They're not regulated. So we have people stop all that stuff because it's just easier to kind of blanket stop everything than to go through their list and kind of stop things one by one. So vitamins, supplements, herbs, all that we stop 2 weeks ahead of time.
And then what do we do about us people that are on like Lexapro and like Wellbutrin? Does that play any factors?
No, that you can continue. And then there's a few, diabetic medications we want to stop. And usually it's the morning of, right? Because you're not going to eat before surgery. So we don't want to give you the medication that's going to drop your already low blood sugar.
Okay. Makes sense. I like
about a lot of bariatric clients are on GLP-1s. How have you guys been kind of managing that? I know that's been hard even in studies of trying to figure out like what exactly is the cutoff, or do you give extra medication or?
Yeah, I think the studies, and this is ongoing because this is still pretty new. I think the studies we're talking or have shown kind of a 1 week before surgery. And so the reason for that, right, is it slows your stomach emptying, right? In the morning of surgery, they're going to give you medications that are going to basically kind of freeze that, right? Anesthesia slows a lot of your bodily functions, and the risk of throwing up and aspirating, which is when it goes down your breathing pipe, is very high. We've started doing 2 weeks because we found that luckily we didn't have any aspirations, but we've had patients, you put their breathing tube down, then usually also put what we call an orogastric tube. So it's going to go in the mouth and into the stomach after they're asleep. Okay. And there were still a lot of gastric contents for patients when they stopped a week ahead of time. And we found that when we stopped it 2 weeks ahead of time, there was much less of that. So kind of before we had a problem, we saw, okay, this could be a problem one day if someone does aspirate. So let's stop it 2 weeks ahead of time. So we usually have our patients stop it 2 weeks ahead of time.
It was interesting because the first of the last round that I had, I was a very early adopter of GLP-1s, and I had gotten on them before they were very popular. And the anesthesiologist had like no idea what it was. Yeah. Mm-hmm. So I was trying to explain it. So I told him, I'm like, to be on the safe side, I'm going to stop like 2 to 3 weeks before. And he was like, oh, okay. So the second surgery I had, like, it's getting more popular at this point. And he's like, I know, he knew exactly what it was. And he was very like adamant that I stopped. And then he gave me extra medication to like reverse the stomach part of it. And it was very funny. And then the last one I had, he was just kind of like, stop 2 weeks before, it's fine. You did fine the other 2 times. I'm like, do you want me to take the medicine again? He was like, I don't think it was fine. I think I didn't realize at the time, but I think what he was saying is when he put the thing down, he was like,
everything's good.
Yeah,
you're nothing there. You did fine. Never had anything. But it was really funny the first time because I understood how it worked. So I'm like, I'm pretty sure I'm supposed to stop. And it's like half-life is like forever because it's a 7-day medication. So I'm like,
yep.
I think you're going to want me to back it up
even more. Yeah.
Even more because it'll have just gotten out of my system if it does. So, but it was interesting because each time I had it, as it became more and more popular, and even I had I just had surgery this year for something else, and like they were very like, when was the last time you took it? How long? We need you to hold it, and they were super on top of it, which I think is just because so many people are on it now, that that they know. But yeah, being very honest and aware of all your vitamins. So like for DS clients, they're on a lot of vitamin K.
Yes.
That's
Potassium.
definitely, that's the blood thinner, right? Vitamin K.
That's potassium, right? Vitamin K.
The element K is potassium.
Thank you.
Vitamin K is the
Yeah,
I
but
feel confused all the time. Gonna be honest.
yeah, so DS patients get extra vitamins that even bypass patients don't take, and I know they are more complicated in surgery. So like super important, even though we don't really think of it as like, oh, that's not medicine. That you follow through.
Yeah.
That you follow through with not taking, what you're told not to take. And even I think, what is it, the one you take for your skin?
collagen.
No, the one people, you can open them and like put them on your skin, or you can take them.
Oh.
Know that. And what does it do?
It's a vitamin. I don't know. It's another one like
Put
you
on your
really.
skin?
The Vita patch, is that what you're talking about?
No. It'll come to me. It's something that's in, like, you can open it and actually put it on your skin, or you can take it orally. It's like one of the letters. Doesn't matter. But like that's another one like you cannot take, and a lot of people don't think of it as a vitamin because it's like, open it and put it on your. It's an oil. It's a fat soluble one.
Because what I'm basically in
ADEK.
2 weeks.
A, I think.
Is it A?
Oh, vitamin A.
I mean, A is ADEK are your fat soluble ones. So I think A might come as a topical. That's the word.
Okay.
Oh, vitamin E. It's E. That's what I was thinking.
Oh, okay. Well, like I said, ADEK are the fat soluble ones. So
yeah,
ADEK. That's gonna be
so
good.
that's the one. That's why DS needs them, because they don't absorb fat.
Oh, I didn't know that. Really?
Yeah. So that's why they have higher needs, because so much of their intestine is bypassed. And so the absorption of fat is very low, which means the absorption of fat soluble vitamins is low. Yeah.
And interestingly, because they're fat soluble, those are the 4 you can overdose on.
But you can overdose.
Too much.
I mean, I knew that
you can overdose. Yep, you can overdose on vitamins, and it's
iron.
Those 4. The rest you cannot overdose on because it'll just go through your system if you have too much, or you'll just kind of pee it out.
But the A, D, E, and K,
and iron.
If you have too much or
overdose, it differs based on each one.
Okay. Are any of them where you would like be hospitalized?
Yes.
Oh, wow. Okay, guys, that's very important then. Think about it. Make sure your vitamins are right.
That's like why it's really important if your child gets into Flintstones and eats a bunch of them, they can get iron poisoning. Like that is a thing.
That is
like, you have to be careful.
My mom got real mad at me because I did like the Flintstone vitamins, and I ate like 3 or 4 of them. She's like, "Stop! What are you doing?" She's like, "Just only eat what I give you." I was like, "Fair." But I didn't know at that time. I was like 12. I was like, "Ooh, I want something that tastes like a candy, and I know these are good for me. I'm gonna do double threat here." And no, I was just hurting myself.
Yep.
I have no clue. What did Dr.
Yeah, and I imagine DS patients must get checked. I mean, I've had my vitamin D levels checked, but I don't think I've had my AE and K checked. But I imagine the patients who are
I mean, all bariatric patients get pretty broadband or broad spectrum vitamin testing, but DS clients in particular have to get them done and often have a bit more supplementation than bypassing.
Okay. Have you done surgery on any DS yet? Dr. Beidas?
Me?
Yeah, like any plastic surgeries on DS?
The king of DS is in our town, so I would be shocked if you didn't.
Who's the king of DS?
Yeah,
Dr. Textera.
He does a lot of DSs.
Yeah, he's like I don't think he created it, but he does a lot of it. So yeah,
he does a lot, and some surgeons, from what I've kind of learned, don't do them. No. They don't even venture that way.
Yeah. No, Smith does over at Advent, but most of at least our local surgeons, maybe a few more are doing Saudi, which is kind of an in between, but they're not doing duodenal switch. You have to be kind of the perfect candidate for that, and you have to be like highly committed for vitamin supplementation, like no history of non-compliance. Like I know particularly for Smith, his his criteria for doing DS. And you also have to have enough weight to lose, because DS, you
Yes.
lose significant weight. So you actually have to have enough to lose, but be healthy enough to have it. It's pretty
So
narrow
it's very rare.
Yeah.
and have high compliance.
It's I mean, I'm not a bariatric surgeon. I've seen I'd say quite a few DS patients. They're usually like the BMI 50 to 60
Yeah.
plus. And I know sometimes they'll even do it in 2 stages.
Yeah, originally that's how they did it. That's actually how they figured out sleeve was like a thing, because they would do sleeve first, and then the people would be so successful, and they were like, huh, that's interesting. Because that was always just step 1.
I have a random question for you, Dr. Beidas. So, if I walked into your office, like old Mel, 308-pound Mel, and I wanted plastics, is that something that you technically would do? Or are you going to be like, no, we need to have you lose weight? Like, what does that look like? Because some people think you can just walk in and be like, hey, Dr. Beidas, fix me.
Yeah. I would say we don't get those very often because we have BMI cutoffs. But there are patients who come in, so we don't really get people who are, I would say, 300 plus pounds in general, unless you're like 7 feet tall. I've had a few guys who were like 290 and 6 something, but they're just like, they come in and they're like all muscle.
Yeah.
Kind of like myself, right? No, I'm kidding.
Oh,
But I have had patients come in who are maybe 250, their BMI is like 38. Our BMI cutoff is around 40, but they come in 38, and let's say they want a tummy tuck, or they come in and they want some surgery, and I'm like, well, you're not a great candidate for this yet. So either you need to lose a bunch of weight, or I'm going to charge you a lot of money, do a bunch of liposuction, then maybe you lose a bit more weight, and then we could do something like a tummy tuck. But liposuction is really not a weight loss procedure. And even then, we can only target the fat beneath the skin, right? So you have skin, fat, muscle, and then inside around your organs, you have another layer of fat called visceral fat.
Mm-hmm.
No surgeon, a weight loss surgeon can help you with it, but they're not directly cutting that out. But as you lose weight, that's some of the fat that you can burn. Generally, you don't cut that fat out like we would the fat underneath the skin that we can take out with, plastic surgery. And so usually those patients, it's just an honest conversation.
I have noticed there's like a growing population of like plus size tummy tucks. Have you seen that too online?
Mm-hmm.
Yeah,
I have. I don't know.
That's what I asked, because I've been seeing it randomly, and I'm like, huh.
Yeah, I'm like, I wouldn't have mind that body shape if I was able to have a plus size tummy tuck and kind of smooth me out. It's interesting to see though, because people are very cruel, because they'll always point it out too. They're like, I could see the tummy tuck scars, and I'm always just like,
so
who cares?
I think the problem with plus size tummy tuck, and I think we might have talked about this on one of our other episodes, is like, what is a plus size tummy tuck? There's no accepted definition. So for one surgeon, it could be a BMI over 35, could be a BMI over 32 for another, could be a BMI over 40 for the next. So I think that's a bit of a, I don't know how to put this in a PC way. I think it can be like a marketing gimmick sometimes, like, plus size can be 33 and you can still get a great result, or it can be over 40 for someone. And I don't think it's a bad idea, as long as the patient understands, has realistic expectations and isn't expecting to look like, someone in a Victoria's Secret catalog, because there's no way someone in a BMI of 40 is going to look like that.
I think the look now more is though staying of size, but then just having like one section stomach.
Yeah, because like instead of having the rolls, and then like, especially,
I don't think they're trying to get tiny.
Huh?
Yeah.
I don't think they're trying to get tiny.
They're not, and that's fine. That's fine. Again, I think as long as there's an understanding of this is what you should expect to look like, don't come in with a BMI. And this is what I do with my patients, Mel, because you were asking. If I have a woman who comes in with a BMI of 38, and not every woman with a BMI of 38 looks the same.
No.
But I'm going to show her like 5 pictures of someone with a BMI of 38 and what that looks like before and after, and what someone with a BMI of 32 looks like, and someone with a BMI of 30. And I kind of have multiple different slides of patients at various BMIs. And so my goal with that is to say, you look like this woman. So maybe maybe she looks like someone with a BMI of 36 to 35, even though people carry their weight differently, right? So it's a number, but it's helpful. And so I'm going to say, maybe you have the body shape like this woman, even though her BMI is 36 and yours is 38. So then I'm going to click through a few slides and say, don't expect this result with a girl who's got a BMI of 30, for example.
Yeah.
And so as long as that patient understands, yes, I'm going to look like this and not like this, then okay, fine, we could do the surgery. I think the other component of it is you have to realize those patients also have we talked about smoking being a risk factor, low protein. BMI is a risk factor for complications as well. So the higher it is, the more risk of wound breakdown, of cardiac heart problems, lung problems, like coming off the ventilator. I mean, is it common? No. The most common one is going to be your incision separating or getting an infection or having a fluid collection with higher BMIs. So there is a higher risk factor associated with it. And I don't know that a lot of these surgeons advertising plus size tummy tucks are having that conversation with every patient.
Being like, hey, there's risk factors if you aren't losing. So I know that we've said this in the older episodes of like, okay, we want you to be at your stable weight for about 6 months to a year, right? So like, what do you have a cutoff for BMI, or you're like, not going to touch you? Like,
I won't see someone if their BMI is over 40, except if it's like a special circumstance. So, like an example of that is someone who, and usually that's going to be someone who's calling the office and my coordinator is reaching out to me to describe it, or a surgeon is sending this patient and they're going to call me directly and say, hey, I need you to see this patient because, and so one example might be their skin hangs like to their knees or below. And a lot of those patients start having lymphedema in that abdominal skin. And so there's fluid that gets trapped in. I think we might have talked about this at some point. Maybe it was someone else. We did.
No,
okay.
We did, yeah.
Yeah, fluid goes in, can't come out. That's the long story short. So that patient needs help walking. Maybe they're in a wheelchair. Maybe they're using a walker. So we'll do is it a tummy tuck? Absolutely not. But we will take them to the operating room, remove that extra skin with all that fluid, help them walking again, maybe getting back to exercising, and then if they lose the rest of that weight, then we'll see them back.
Another round. Got it.
Correct. Yeah, generally those patients still need weight loss surgery if they haven't had it, and some have, and they just have that kind of hanging skin that's so bad that they can't really do anything else, right? Like a woman with large breasts. We have a lot of women who come in for breast reductions. Their breasts are like heavy, hanging down. And they can't exercise because, how do you like put 5 pounds in a bra?
Oh, for sure. I know people that have had to wear like two to three sports bras just to keep it in, so they don't have like anything like moving aggressively or hitting them, to be honest with you. Like, it's wild. And I mean, I understand the clap back. Like, I get the clap back every once in a while. So okay, so now we have a little bit more to handle. Okay, so is there anything else that we need to know about like pre that we need to do to make sure post is great? Have we missed anything?
I think the one other thing I can think of quickly, and I think this is not like something we need to harp on, is just making sure your other medical conditions are well managed, right? So if you're diabetic, we have cutoffs for what your A1C should be. If you've got heart problems, and we do a lot of this by asking questions to patients if they've had problems with anesthesia, with bleeding, with clotting in the past. So really just optimizing them. A lot of that's on the surgeon, but it does help if you have a heart problem. You should see your cardiologist at least once a year, if not every 6 months. If you have a lung problem, same thing with your pulmonologist. Rheumatology, I would say the rheumatology conditions are some of the worst because some of those conditions you're on medications that can affect your wound healing.
Yeah.
And we have to take patients off of those often for at least a short period of time. And it really messes with that condition. But the flip side is their wound breaks down entirely if we keep them on the medication. So I think that's one of the hardest ones to balance. And the other one is patients who are on blood thinners for one reason or another.
Oh, I didn't even think about the chronic illness people, because that's kind of like RA. Is that what you're talking about? Like rheumatoid arthritis?
Yeah.
Because
Hmm.
we have a lot of people actually in the community that have some sort of like
Yeah, lupus.
autoimmune disease. So
Lupus, yeah.
yeah. So
Yeah.
when you have patients that come to you with kind of this, like, do you like what do you do? Like, you still do surgery and just tell them the risk and we just kind of move forward, or like how?
So if you see a specialist, actively at least, if you have a lung condition, if you have rheumatoid arthritis and you're on, it's called the DMARD, the disease modifying agent, which a lot of times are those medications that inhibit your ability to heal. Steroids, for example. So we will ask you to get a clearance from that doctor, or at least a note saying, this is how we are going to manage this medication or this patient, for, let's say the 2 weeks or 1 month before, and 2 weeks to 1 month after surgery. So just communicating with that doctor, and making sure the patient, goes back and sees them and tells them, hey, I'm having surgery. A lot of times some of these doctors don't know exactly what we're doing, but we'll tell them, like, this is a 5-hour surgery, it's a breast reduction, or this is a 10-hour surgery, a lower body lift. Again, I don't think some of these doctors even know what that is, but we'll tell them it's 10 hours of skin removal. And then we want them to send us a letter back saying, okay, got it. We're recommending they hold medication A for 2 weeks before surgery and restarting it 3 days after surgery, or whenever you find it acceptable. So just communication between the two physicians.
Nice. Okay, so now that we've had surgery, we've already gotten home because we figured that part out. We're in our Fajas. Is there, we're not eating a bunch of soup, and making sure we're not having too much salt. Is there anything we can do with our wound healing? Like, is there any like ointments that we should be putting on? Is there, what can we do to make sure their like incisions don't open?
Great question. So for the first few weeks, you just want to follow your surgeon's instructions, and I think everyone's going to do, things a little differently. I like to glue all my incisions shut unless patients have allergies, because number one, that pretty much allows them to shower the next day, which, I mean, maybe that's not important for everyone, but for me, I feel like it's gross if you can't shower after a day or two.
Oh yeah.
What was your experience, Ashlyn?
Oh, I had the one who wouldn't let me shower if I had a drain in.
Oh yeah.
I went a month.
I don't know where people get these things from.
Terrible. No, I was really appreciative of the last surgery, because I did have a little bit of a hold, but I was able to shower relatively soon after, and that definitely, it takes it out of you. It's exhausting. I would always recommend shower chairs, even if you have like even a relatively like minor, you don't have a 10-hour surgery. I still recommend a shower chair because you don't want to pass out.
Yeah.
And it's weird if you've been sitting, there's probably some medical aspect to this, but when you've been sitting a long time and then trying to stand for a long period of time, I had a very weird sensation when taking the faja off that made me pretty lightheaded and didn't make me feel particularly great. So there's like this weird mix of like, you get out of the faja, you're then trying to stand in the shower. I always had drains, and and my drains would stay in forever. So I had like my, holder of drains on in a shower. So I didn't have a shower chair, I think, for like the first one. And then after that, I was like, this is ridiculous. They're like $20. I'll donate it. We have like a place that like people can get like donations of like medical equipment. I'll give it to them when I'm done. Like it's no big deal. I would say like from a like stuff standpoint, I had a pillow, like I got it on Amazon, where it had all different kinds of pillows that were like triangles and like a round. So it helped you like keep your knees up, but like sleep sitting upright, but in a more comfortable position. And you could kind of flip how the pillows were oriented. So like if you needed to lay down, but only have your legs up, or you needed to be fully up. I slept in the bed for most of mine, but I had one I couldn't sleep in the bed. I have a reclining couch. So I'd sit and then it would recline me up, and then I'd put all the pillows in and I'd put all the pillows around me. So I would sleep kind of like this. It was not the most comfortable thing ever, but made do. Trying to think of other things. Oh, we talked about like you may need a toilet riser, especially if you're having any kind of muscle repair. It may be really challenging to sit on the toilet and get back up from the toilet. There's also like a latent
sorry,
urinal.
can I add something? For our thigh-plasties, I think patients have said that, what are they called? Standing urinals for women? I don't know
the
exactly what the
She-Wee.
term is.
She-Whiz, the She-Whiz.
Yeah.
She-Whiz. I call it a She-Wee. But yeah, I have one, actually.
People use them for camping. I
For fun?
had never seen them
Oh, okay.
before camping, or I had a client that just has like
I
a
have to Google what this looks like after we hang up.
it looks like a pink funnel.
Yeah, it's literally like a funnel that suctions to your
It's like-
vajayjay, and
Yeah, it's skiddier though.
yeah,
I have a client who's just like,
or
yeah, lady shaped.
Thanks for the visual.
You don't like feel all over your leg.
yeah.
You know,
That makes sense.
ladies.
No one
I
wants
got
pee
it
on
for
their
camping because I was sick and tired of getting pee on myself or on my clothes of some sort. I am not a good aimer by any means.
I think that was the original use of the She-Whiz is for women to be able to pee outside, like when camping.
Yeah. Yeah.
I'm pretty sure that's.
Now I
I don't think it was
really-
made for surgery.
I keep it in the car now because, like, well, why not?
You never know.
If you're ever stuck somewhere, you got a She-Wee. Because you know what? My niece, I love you, M, but for some reason, all the way up to, like, from Salem to Seattle is about 3.5 hour drive. She decided to not stop at any rest stops. And so all of a sudden she had this huge, like, urge to pee. She's in traffic and she literally filled up a big gulp. Like, fucking ridiculous. And then she did, like, she had to, like, stop, pull over, pour it out. I'm like, this was
It would have been better off to stop it.
This is why we have rest areas.
I think also specifically with Fajas, since you don't want to take them off and put them back on, something like the female urinal or She-Whiz is effective too, so you don't pee on the urinal or on the Faja. The Faja lady that made mine put a zipper in the back, which was great, and had a string too, so you didn't have to take it off for any bathroom concern, which was fabulous because I had friends that did not have that, and trying to take that off. I think someone I knew that actually injured herself on accident. Post-surgery, you could be constipated, and if you take a bunch of medicine to try to clear that, and then that can create some urgency you didn't mean to cause, and then now you're trying to run to a bathroom, take a Faja off at the same time, and she fell and hurt herself and went all yeah, it was awful.
Oh
no. So I definitely recommend that you, like, especially if you can find someone to do some of the specialty stuff to the Faja, like the lady in Orlando that does ours. She always puts the zipper in, so that way it's a very calm, very collected, you know, like, you know, because it can be hard to take it off and put it back on. They're very tight if done properly. I mean, it's meant to be tight, so it could be a production. Like the one I had sleeves and shorts, so I like a full-on suit because I get a lot of swelling in my armpit. So if you did that like cut off, it was causing a lot of problems. So I actually had her sew on sleeves to mine. So we could, one, get some compression right in here, but also not cause a cut off where it was causing like tissue breakdown from like the rubbing. Even I had like foam and everything. It was incredibly uncomfortable.
With your lady, is she like, does she take people like that? Where like, if we put her stuff in the description, would people can find this person that you went to? That way they can make custom.
Yeah, it's the Forum RX lady.
Oh,
yeah.
Perfect. Okay, so
if you're in,
so that way,
if you're in Orlando, the downside of it, the good thing is they're custom made Fajas. Like she makes them to you, but if you're not from in town, you're not going to get the benefit, and part of the cost of it is that she takes it in for you, and that's why they're pretty expensive.
Cool.
But she like follows up. Like you go in every other week, you have it, and she makes it smaller and smaller, and can So like for me, when I was going in like crying because my armpit hurt so bad, she's like, we'll just put on sleeves. And then the next time I knew, I just had her put on the sleeves before we even started. So my two Fajas already had sleeves and had legs, because the other issue I was having is the swelling will collect anywhere that doesn't have compression. So it was squeezing it out of the middle of me and then going to my legs. And I had never had that before. And so we needed the compression to follow through into the knee so that it actually was like following. Yeah. So I like, and it was summer for them.
Wild.
Yeah. It was hard to wear out of the house. I mean, I could, but I had some like modest, those like modest dresses that are like up to here and like down to here. Like Target had a couple, and I had 2 that I could like throw on, and it covered everything. But because I didn't want
And
it
a-
to cut under my breast either, so I had to go like all the way up, all the way down, all the way down. So yeah.
Oh, dang
even
it.
some of our out of town patients will use them, and they'll do the measurements, kind of like a telehealth visit. They'll have you take some measurements or have someone take some measurements for you. But as Ashlyn said, they are pricier. I don't know if they have different pricing, like if you're not going to have a whole lot of adjustments if you're from out of town. But they're definitely pricier than the regular garments, but they are much more fitting. One of our big patient populations who it works very well for is lipedema patients, because they're generally not going to fit into like an off-the-shelf garment. So we send a lot of our lipedema patients there.
Yeah.
Just impressive, like how much you can do now. Like with all
Yeah.
the, you know?
Yeah.
Yeah, because part of the issue of swelling, which I didn't realize, is that it causes pain. So like some of the pain that you're feeling is actually swelling. And so if you can control the swelling, you're actually controlling pain. And so, you know, when I have clients that are like, oh, I find it annoying or whatever, but I'm like dying, I'm like, okay, so we've got to like, you know, not ignore the recommendation. The recommendation isn't just because, I don't know, they want you to suffer in a sausage suit. It's because they, you know, it's because it's going to cause you pain if you don't. And so I think sometimes because this is surgeons' world, they don't always get to the why. Like I had no idea why I was supposed to wear compress. I was like, okay, I'm rule follow with stuff like that, especially if I pay a lot of money. I'm gonna follow the rule the best of my ability.
For me, your body, you need to pay attention and make sure you're following to the T, because that's scary.
Also, like, I think we kind of glossed over this. Like, you should not be putting anything on scars, correct? Because I didn't know that, and I was putting like I thought like lotions and potions like that would be helpful.
Yeah, so Mel asked that earlier, and we kind of got sidetracked. So, you know, we again, I would follow your surgeon's instructions, and if you're going to do something, I would let them know. So, because we glue, right? So glue doesn't actually come off by itself. Your skin sheds. And so glue lasts about 3 weeks, which is how long it takes your skin to shed. And so we don't recommend putting anything for the first 3 to 4 weeks because you're just wasting your money. It's not actually getting onto the incision. And it's still too early really to put anything on until about that 3rd or 4th week. After that point, if it's healed, you know, we have a few recommendations that we make. So number one, we like patients, if they're going to use something, to use a silicone-based product.
Okay.
And there are some out there that are not pure silicone. The one we sell in the office, the brand is Silogen. I think you have to buy it from a doctor. You can't go online and buy it. But it is 100% silicone. So there's nothing else mixed in. You shouldn't have, you know, silicone is a very inert substance, right? That's breast implants are made from a silicone shell. And so you shouldn't have any reaction to it. The other thing we also do for our cosmetic patients is include like 1 session of laser or light therapy, depending on what you need. So scars sometimes need different types of treatment based on how they're healing. So there's light therapy. We use a broadband light device, and that's going to treat redness. So if your scar is very red after 3 or 4 weeks, we might hit it with some light therapy to kind of cut down on the vascularity.
Okay.
Or if it's starting to thicken, then we're going to use a laser, which is actually going to help thin that layer down and help prevent or maybe decrease your risk of getting a hypertrophic scar, which is when it starts. If you've seen patients who have like thick scars, a lot of time patients.
Yeah, I have a hypertrophic.
I don't know that yours is.
It's just the one on my arm.
Maybe if it's a bit wide. Arms are notorious for widening. A lot of patients call those keloids, but keloids are like much worse than hypertrophic scars. Keloids look like cauliflowers or mushrooms growing out of your arm or your body. Hypertrophic scars are usually just those raised red scars, and so we want to hit those with a laser treatment. So I'd say those are really the 2 big. So, and compression actually can help keep a scar flat, right? Because it's not giving it that space to swell, and swelling can cause that scar to widen or separate. So we really recommend for scars compression. Again, it's comfortable, as you said, Ashlyn, and it's going to help with pain. We recommend Silogen or a silicone-based product, and we recommend laser or light treatments.
I had a little part of mine where we injected it. I don't know what we injected it with.
With steroids, probably.
Yeah, I had like
Yeah.
where I had a T junction. Both my T
Did it,
junctions raised a
was
little.
it getting thick? Yeah. You can do steroids. Usually that's something you would do months later, not usually like in the first 6 weeks, for example. You could, I guess, in theory, but most of the time we're usually doing that at about 3 months. The problem with steroids is they tend to change the color. They tend to make it lighter than the rest. So you might have a darker scar, and now you've injected it, now it's going to go lighter than your regular skin. And the other thing it tends to do, so the scar is raised, let's say, or folded on itself, and when you inject it, really what steroids are doing is it's kind of making your body kind of down regulate its healing, but it tends to widen a scar. So it goes from being thick this way to wide. So it's just separating that scar. So we tend to try to avoid steroid injections. I'm not a big fan of them. I'd rather go and revise a scar and then tell a patient, buy a laser package and treat it with the laser if it's going to get hypertrophic again.
Oh, nice. I didn't even know there's a thing for you can revise scars. Like that's.
Yeah. So you just, in the most cases, if you've given something like 6 months, it's gonna settle and you're gonna be able to pinch more skin.
Okay.
And then a lot of times you can go in and just cut around the old scar and then suture it shut again. And then you try something different the second time so that it doesn't heal that way again.
I can't think of who, but there definitely have been people who've done some scar revisions. Usually it's they're going in for round number 2 and then they revise a previous scar.
I was going to say, I've never heard someone just get it revised. It's always been within like another surgery.
Yeah.
Yeah, I'm trying to think. We did one a few weeks ago where this woman had a brachioplasty elsewhere and then her scars weren't great. Her skin was, I'd say, moderately tight. We could still pinch some. And we had planned a scar revision. Ultimately, when we went in there, we kind of just redid the whole brachioplasty, but she just wasn't happy with her scars.
That's fair.
And then we did some neck stuff, but nothing major. So really, it was mostly a scar revision that we went in for.
That would probably be the only scar I have that I would revise, is the ones on my arms, but I don't want to deal with having arm scars again. Like going through
They're the worst. Yeah, they're the worst in terms of healing. Like I said, I tell all my patients arm scars are, they were like, how's it going to heal? How's it going to look? A, you got to give it like 3 years before you really see a change. And B, they tend to heal either wide or thick.
So no matter what, it's going to be.
Yeah, because my concern is we revise it and I end up with the same thing.
Right.
With the same thing. Yep.
Yeah,
that's
what I would be nervous about. And I would be very frustrated as a patient if that's what happened. So it's like, sometimes you just got to be okay with a scar. Like, I think going in, like because me and Ashlyn talked about this, obviously, through the episodes of like, she doesn't mind scars. I have a little bit about scars, but not huge. But like, I think if you're going in, you just have to be mindful. There's just going to be scars. Like you can't.
Yeah. The easiest patients, you never want to convince a patient. Like I shouldn't speak for everyone. I never want to convince a patient that like you should get this done or like this is the right answer for you. The best patient in my mind who comes into my office is the one who either kind of like you were just saying, I don't care about scars. Great, then we're gonna put scars everywhere. Or this is so bad, especially in the arms, because that's one of the more visible scars when patients are moving. But they say this is so bad, I'll take the scar. Anyone else, like I saw someone a few weeks ago I told her, she was like, oh, can't you just like do lipo and some skin tightening? And she's got like some skin hanging out to here. I was like, yeah, I can. I was like, I'd be ripping you off because you'll come back and tell me now you have all this loose skin. So I was like, I won't do that. I was like, you might find someone who will. I don't think you'll be happy with the end result. So, I'm not offering you that. I'm happy to do a brachioplasty, but you're going to have a scar.
Yeah.
I'm not sure she booked surgery. I can't remember what ended up happening, but I'm sure there's people out there who would do that and tell her, yeah, you'll get a decent result. I'll do your, because they're letting the patient drive that conversation. And I think to some extent that's okay. But I don't like the idea of doing a wrong surgery on someone.
No, and I appreciate that honesty too. You're like, I'm not comfortable with doing that. I'd rather just do the procedure that I know will work than take your money, because these are expensive procedures. Like why, I would want it to be exactly the way that it should be done with a proper professional. Like, I don't think anybody should be going into this as like a quick fix for anything.
Correct.
So
I will say on the flip side, though, I had a lady, and this was surprising to me. And I talk about this, like I lecture on this every year at our society. And this doesn't happen often, but there was one lady who had, loose skin in her arms, needed a brachioplasty, but she had a lot of fat. And sometimes in those patients, I'll recommend staging the brachioplasty. So you lipo most of it in the first stage, and then you come back and do the skin removal. The reason for that is it allows you to even the tissue thickness, and there's less likely a need to have to go back and do a removal of skin. Because a lot of times with the arms, you get them as tight as possible. 6 months later, you can pinch another like 2 centimeters again.
Okay.
Ashlyn, I don't know if that was your experience, but that's one of the ways to decrease that risk. So we did her, it's very common. So we did her first stage, we did the lipo, and then she came back like 2 months later, and she said, you know what? I don't want the scar. I still have a bunch of loose skin, but she's like, I don't care, because when my arm is down, it looks normal. All the loose skin's on the inside. And so I don't want to say that changed a lot of how I mean, I do realize that not everyone's idea of good or an aesthetically pleasing result is the same.
Right.
But I found it very interesting that I was like, but you still have all this loose skin on the inside of your arm. And she was like, I don't care. When my arm's down, if I'm wearing a tank, like even a tank top, people don't see that. So, and she was like, and I don't want that scar. I think it's hideous.
People's tolerance level, both directions, always surprises me. I'm willing to do this, but I don't want this, or I'm willing to do this and I would go here. I think it is very person dependent. Also, like I saw there's a guy that a plastic surgeon who does a lot of lipedema in the legs. Can't think of what his name is, but it was funny because he was like, oh, this guy, he did where the thigh scar is high and it's across instead of down. And he was like, oh, this was the wrong choice. This surgeon should have done, the other scar. But it was so funny because I'm like, the lady was talking about how she really doesn't want scars. So I'm like, I have a feeling she told the other guy the same thing. And she ended up doing like he ended up doing a regular one and got much better result. But I'm like, I'm hearing the person do the like 2-second Instagram reel and her be like, well, when I went, we wanted to do the least amount of scars and blah, blah, blah. And I was like, I don't think then it was the surgeon.
Yeah.
Yeah. I think it's a tough challenge sometimes, right? Because patients want one thing, and you can't get that result. It's almost like I want the best result, but I don't want a scar. Well, in some patients like this lady, you need a brachioplasty. So I have to put a scar. I can't do it without it.
Yeah.
So it is very difficult kind of as a surgeon navigating that. And in, I might see like 10, 15 patients a day, and each of them is going to fall on a different part of the spectrum of how much they're willing to accept a scar and where their expectations of a good result is, right? They all are going to differ in those two aspects. So navigating that is not easy.
Makes sense. All right, guys, we got to wrap this bad boy up. We can always talk more on a different episode because we just can keep talking, and I have so many more questions, but we have hit our time. So I want to say thank you so much for Dr. Beidas being a part of this, and of course Miss Ashlyn, who's been helping so much through all of this. You guys are great. I wanted to point that out. They are experts in their fields, and this is pretty cool. Like I've learned so much. So do you guys have anything else to add before I let you guys go?
Follow your doctor's orders.
There, that's great words. Yes.
Follow your doctor's orders.
Yes.
They want to be able to put you in their afterbook. If you don't follow their orders, they cannot put you in their afterbook.
No, they
cannot. We should talk about, we need an episode just on that.
Ooh, write that down. Let's do it. All right, guys, you guys know the drill. Thank you so much for following us. Make sure that you're liking, subscribing, and all the things that we've talked about will be in the description. So if you have any questions, we'll have resources for you to go and click on, so that way you can help yourself with more things. That way you're well prepared for your plastic surgery, because that's really what this is all about. So, all right, well, you guys have a good evening, and we'll chat next time. Bye.
Bye.